Dr. Park, whenever you are ready, we will begin. So
I think you can start now.
Welcome, everybody. It is my pleasure to be here today. Welcome to Vision Care's Phaco training course. And I'm so delighted to see some old faces and familiar faces and some new faces. You can see here that we have a group that is joining us both from Ethiopia and from Tanzania. And so it is my pleasure to see all of you. And I'm hoping that this will be a valuable experience. The goal of today is to introduce our Phaco training course to you. I will be giving an introductory lecture, and then we're going to outline the course and its objectives and some of the deliverables that we are anticipating, and the schedule and the dates. Obviously, I would like to, well, first of all, I would like to introduce Amy On. She's our Executive Director for Vision Care. She's located here in New York, and we're happy to have her here and helping to organize this part of the course. I would like to say also hello to Sedale in Addis, who is from Vision Care Ethiopia, and she has been in contact with those of you who are participating from that site. And I would like to also introduce Ms. Jian Park, who is from Tanzania and who is leading our program in that country. And we are so delighted that she has helped to organize and to be part of the course here. So with that being said, my name is Lisa Park. I am an ophthalmologist in New York City. I am the board chair of Vision Care USA. I'm a faculty member and have been teaching cataract surgery for the last 20 years. For the first dozen years of my career, I was the residency program director at New York University. And I am now a faculty member at Columbia University. I am also the division director for comprehensive ophthalmology. And I know many of you. I've seen you at some of the conferences, and I'm looking forward to seeing you again this summer. With that said, I'm going to go ahead and share my screen here. Oops. Wow. Okay. So what I would like to do is I'd like to give an overall introduction into our Phaco training course and also some background into phacoemulsification. My understanding is that all of you are ophthalmologists who are currently practicing cataract surgery, but in its manual form. And so our goal here is to introduce the concept of small incision phacoemulsification, and some of the means and techniques for performing this in your countries. So this is just where I'm coming from. Again, this is New York City. This is the E.S. Harkness Eye Institute, which is actually currently torn down and being reconstructed. But this is where our campus resides. And among our faculty, we have some of the innovators and leaders in our field, including Dr. Stephen Trokel, who invented LASIK, and also Dr. Stanley Chang, who is a retinal surgeon who pioneered the use of gas in retinal surgery. Which I understand is not being performed currently in your countries, but that I'm hoping that he will come and he will be able to teach that also. I just want to talk about the history of phacoemulsification because it did also originate here in New York, although it did not originate at Columbia University. This is the hospital where phacoemulsification was first invented, and this is the place where actually I originally trained. This is the Manhattan Eye, Ear, and Throat Hospital, and the photo that you see on the right is a photo of Dr. Charlie Kelman, and he is the man who invented phacoemulsification and changed for us dramatically the way we approach eye surgery. This happened in the late 1960s, and he developed this at that time. The story that he told at that time was that before then, everyone was performing manual surgery. And manual surgery, as you know, can be fraught with complications. And so the patients at that time were being admitted to the hospital and stayed in the hospital 2 weeks after surgery. They did not receive an intraocular implant, and we waited until these cataracts were very, very dense because the complication rate was high. He decided at that time there must be some better way of doing this. So he received a research grant in order to try to attempt other methods. The story, as he told it, was that he tried everything possible. He had patients lying face down. He tried to use all types of instruments, and really it was very difficult. And he spent a few years, and his money was running out, and he was very discouraged, and he hadn't gotten any closer to being able to perform this procedure. And so he was about to give up. And the story, as he told it, was that he had neglected himself during this time. He wasn't sleeping, he wasn't eating. And so he finally decided, you know what, I'm going to give up. And he decided to take care of himself. So he went to get his hair cut, his beard shaved, and then he went to get his teeth cleaned. And when he went to the dentist, he was sitting in the dentist chair, and his teeth were being cleaned, and there was something vibrating in his mouth. And he asked the dentist, "What is that?" And the dentist said, "Oh, it's a newfangled thing. It's called ultrasound." And the story, as he told it, was that he said, "Eureka, this is it." And that he ran out of the dentist chair with the bib around his neck and down the street back to the hospital. And he went into the laboratory and he used phacoemulsification. And that is how this began. So this photo that you're seeing here is one of the first cases that was performed on a patient that was already being enucleated for a choroidal melanoma, who agreed to be the first case. You can see that the machine takes up almost the entire room. The surgery was performed over the course of many hours, and the patient obviously had the eye removed, but this was the very beginning in which he understood and knew that this was something that could be used. And that's how that evolved. So we now fast forward today. It is now 50 years later that we have now been doing phacoemulsification. The interesting thing is that when he developed this, it actually was not well received. He actually received much criticism and was almost banned from the American Academy of Ophthalmology. He was blacklisted by many physicians who said, "This is malpractice. You can't be putting ultrasound in a person's eye." But he persisted, and it was very fortunate that he had people who believed in what he was doing. And one of those people was his trainee, Jack Doddick, who was my chairman and who was my mentor. And he was the one who taught me phacoemulsification. So although this was invented in the late 1960s, it actually was not widely adopted until about the 1980s, when the first foldable lenses were invented. So when foldable lenses were invented at that time, people realized that you could go through a smaller incision, and there was an advantage to doing so. And that is what propelled this technology. As you know, there have been many iterations now of this technology that have evolved. And so this has become now in the United States and much of Europe, the standard of care, and that most doctors now do no longer know how to do manual surgery. And so this is a valuable skill that I feel is very important in those very dense cases. And we're going to talk about the advantages and disadvantages of using manual surgery and using phacoemulsification, of which I feel it is very important to have both of those techniques in your armamentarium. I'm going to talk a little bit before we go on into the nuances of phacoemulsification, what it means to learn how to do this technique. As I've mentioned, I've been training doctors in this for the last 20 years. And in New York City, where we have everything at our disposal, this is what that entails. These are photos of my residents that I've trained. Oops. And actually, I'll just show you a video first of what exactly we're talking about. And I'm sure all of you, of course, know, but this is just a diagram so you can see what exactly we're trying to do. And this is a cross-section, obviously, of the cornea. We're injecting viscoelastic in order to protect the endothelium and to provide some space. We perform a curvilinear capsulorhexis opening in order to prevent any kind of radial tears. We're using the phacoemulsification to remove the lens material, and then we fill that space with a foldable lens. When this first started, we were going through a larger than 3 millimeter incision, and that has gradually become smaller over time. And so that many of us were performing in a 2.2, 2.4 millimeter incision. These are self-sealing. There are no stitches involved. And that is now the state of what we are doing. And so this is just a surgical video that I'm sure you're familiar with. There are many different ways and different aspects of the technique, but this is a technique that we use for very dense lenses. We're making a 1 millimeter side port incision, injecting trypan blue to stain the capsule, injecting viscoelastic, and then performing a CCC and then removing the nuclear material. In this particular case, this lens is actually quite dense. And so the technique that's been used is what we call a divide and conquer technique, or a stop and chop technique. And this is using the ultrasound in order to break up the lens into smaller fragments, using a second instrument through another side port in order to provide us with some ability to manipulate this lens. You can see that there is a protection with a sleeve around the phaco tip, because that ultrasound generates energy and you can burn your wound if you have too much phaco energy. So it's important that you have that tip. And we'll talk about some of the instrumentation. This is now injection of a one-piece acrylic intraocular lens that goes inside the capsular bag, and then removal of the viscoelastic. And you can see here that that is a self-seal. These are all self-sealing wounds. What are some of the main differences from doing manual surgery to phacoemulsification? One is the size and location of the wound. Usually with manual surgery, you're performing a scleral tunnel, whereas in phacoemulsification, most of us are going through clear cornea. It is a little bit rare to go through scleral tunnel, although that is still a possibility, and something that I actually currently do when I come to visit you because of the phaco machines that we're using. The second is how we make the opening in the capsule, and that is doing a curvilinear capsulorhexis versus a canoper or a discontinuous opening for the capsule. It is important that we use a curvilinear opening when we're doing phaco, because the radial forces from our manipulation of the lens can cause radial tears that open the posterior capsule. And so mastery of the CCC is very important. Nuclear disassembly, obviously in manual surgery, you're removing the lens in its entirety. So prolapsing it out of the capsular bag and then bringing it out of a scleral wound. In phacoemulsification, we're going to break up the lens into smaller fragments and aspirate them using the handpiece. And then for an intraocular lens, when you have a large incision in manual surgery, you can use a non-foldable intraocular implant. These are usually made out of PMMA, which are not foldable, but they are very sturdy and also very inexpensive, versus a foldable lens, which can go through a smaller incision, which is what we are using traditionally. This can go through a 2 millimeter incision, and they can be made out of materials such as acrylic or silicone. The mechanism by which phacoemulsification works is through the use of ultrasound in a handpiece with a piezoelectric crystal. And so this is conversion of an electrical current into a vibrating crystal, which generates mechanical energy. That mechanical energy then makes this phacotip go forward and backwards at a ultrasonic speed. That generates these cavitation bubbles. These bubbles, as they're exploding, generate an energy, which then break up the lens. So this is the primary mechanism of phacoemulsification. It's important to understand that this is the mechanism, because then that dictates your technique and some of the complications that can occur and how we mitigate those complications. So again, it's creation of these cavitation bubbles. I'm not going to talk about it today, but as you have probably heard, Many of us are using now femtosecond laser as part of our cataract surgery. The mechanism of femtosecond laser has a similar principle, and that is the generation of these cavitation bubbles, but at a femtosecond size. And therefore, we can limit the amount of heat energy that is generated and therefore protect our cornea. And that is the reason many of us are using femtosecond laser. But today, we're going to be talking about the use of ultrasound. The machine in ultrasound, in phacoemulsification looks as the following. You can see down here, again, you have this phaco handpiece that is entering the eye. It is connected to a irrigation bag and then to a pump. So the pump is what generates the ability to suction this material out. We talk a lot about what is the pump, what kind of pump is it, because that also dictates the fluidics, meaning that obviously if you're taking something out of the eye and you're replacing it with fluid, that mechanism by which we do that can generate anterior chamber instability. Anterior chamber instability is when there's too much that's being aspirated and not enough fluid that's going into the eye. And when that happens, you get collapse of the anterior chamber, and you can then penetrate and puncture the posterior capsule. So it's very important for us to understand the phaco machine, its settings. How do we adjust the fluidics and the mechanism by which we're removing that lens material in order to minimize the anterior chamber instability and to prevent them from being complications. And so that is why some of the machines that are being used, if you operate with various machines, they have various mechanisms by which they do this. And this is what makes the challenge of trying to do this successfully. One of the difficulties that we have is that the phaco machines that we're using in the developing world often come with disposable components. And so that is expensive and inefficient, although it can allow for us to have better fluidics. And so the machines we are generally using when we come to operate in Ethiopia and Tanzania are machines, not that they're old, but they're machines that are more sturdy because they have reusable parts. And so the fluidics are going to be slightly different. And that is why the technique by which we have to do this has to be modified. And these are examples of some of the machines that we are using. So hopefully many of you are familiar with the machine on the left, which is the Oertli machine made from Switzerland, which we feel is a very, very good portable machine. The fluidics are actually quite good, but it is also a machine with reusable parts and of which it is very portable and small. And so that is the primary machine that I like to use. The other machines that you're seeing to the right include a small Sovereign machine and then the Alcon Infinity machine. These machines are actually now outdated here in the US, and we are looking at now the 5th generation phaco machine that's coming out. It is quite big. It is not portable. It is very difficult for us to bring that to work with you, but it is something that is currently what we're using here. So what are some of the complications that we have to be concerned about? And that is, once you introduce phacoemulsification, we worry about the loss of corneal endothelial cells. And when there is too much energy that is being used and too much heat that is being generated, or the techniques are not good, meaning that the viscoelastics are not protective, or you're using a technique which touches corneal endothelium, then you can result in complications that you've probably seen, which include corneal scarring, decompensation of the cornea, and that requires a corneal transplantation. When I trained, that was the state of the art, was that if the cornea failed, that we actually had to transplant the entire cornea. Today, we are now performing DSEC. We're doing a endothelial transplant only in order to maintain the integrity of the eye. The conditions under which we currently modify our techniques for to protect the endothelium include specifically Fuchs dystrophy, where we know that endothelial cell count is low, and also very, very dense cataracts. The second major problem that we have to overcome in phacoemulsification is posterior capsular rupture. And here, usually that requires then retinal surgery. So when you have a posterior capsular rupture, you can obviously drop the nucleus back, you get vitreous prolapse. That vitreous prolapse, even if it is cleaned well with an anterior vitrectomy, can still cause traction on the retina, including retinal tears, retinal detachments, and long-term macular edema. And so these are the challenges that we have to overcome when we're doing phacoemulsification and things we have to be aware of in our technique. And so I wanted to get back to what teaching for us requires in the United States. And then again, this is something that we train our residents such that once they graduate from our program, they are proficient in phacoemulsification, and it is a lot of effort and time that was required. And so this is the program that we set out for them. The first part is a didactic curriculum. And as you can see here, that composes, from my standpoint, three major components. One is a cataract symposium. So we talk about the steps of cataract surgery, how to perform each of those steps. The second is we actually have in January a month-long didactic course that includes the basic science course in ophthalmology, where we talk about all of the theories and principles that underlie phacoemulsification. So this includes an extensive conversation about biometry and IOL calculations, the phaco-dynamics, which include how do we modulate our energy and how do we adjust our fluidics. We talk about protection using ophthalmic viscosurgical devices. And then we talk about advanced technologies and optimizing our refractive outcomes. This includes things like laser surgery, use of specialty lenses, including astigmatism correcting toric intraocular lenses and intraoperative aberrometry to take measurements on the table in order to adjust our lenses at the time of surgery, and the use of premium lenses such as presbyopia correcting intraocular lenses. The third part of our curriculum, of the didactic curriculum, includes a video conference. So I meet with our trainees on a monthly basis. They record their videos, they present them at this conference, and then we talk about complications and challenges that they're having. And so these include things like what happens and how do you manage a posterior capsular rupture? What do you do with floppy iris syndrome or capsular instability? How do we fixate or choose an intraocular lens when there's no capsular support? And then what are the strategies that we use when there are unusual circumstances? And this includes the mature lens. And so for all of you, that is what you're most familiar with. That comes in our video surgical conference of complications. The second part of their curriculum includes the dry lab and wet lab teaching, and that is performing steps of surgery that is not with a patient. And so these are the four components that our trainees currently undergo, and that is I teach at an intensive cataract course that occurs over the course of a weekend in Boston at Harvard University, and we give again these lectures and we talk about all the possible complications, and we actually have them do hands-on wet lab course. They also participate in a day-long wet lab course during our basic science course. We also send them for a week to a place in New Jersey where they use this Help Me See simulator. I don't know if any of you have seen this. This is a simulator that's now been rolled out to parts of Africa. The Help Me See organization is a nonprofit that donates these machines. I'm trying desperately to get one in East Africa. I believe they're going to be rolling this out in Tanzania shortly. It is currently based in Madagascar. And then we also do regular wet lab courses in our facility where they're using various eye models in order to perform practice of steps of surgery before they go and operate. And we will talk about some of those eye models that you'll be using also. And then the third part of this is learning and getting hands-on steps of surgery during the course of their training. So our residency program is 1 year of general internship and then 3 years of surgical and medical training in all aspects of ophthalmology. But for phacoemulsification specifically, this is the stepwise course that we use, and that is in their postgraduate second year. They start to participate in steps of surgery using a backing in approach. That means they'll participate with their senior residents, but they perform the insertion of the lens or wound construction or irrigation and aspiration. And then in their PGY 3-year, they will participate in 10 cases during that year. And in the last year, which is when they primarily do most of their surgery, the requirement for graduation is that they perform 140 surgical cases as a primary surgeon, and the average number in our program is 200. So 200 cases in order to be then considered a phaco surgeon. Many of them go on after this to do postgraduate training in complex anterior segment surgery, glaucoma surgery, retinal surgery, etc. But I just want to show you what the criteria are and the amount of effort and time that we're doing in order to teach them phacoemulsification. The last is how we give them feedback. And these are our guidelines for how feedback is given. We grade all of our trainees on their technical skill. And this is obviously a very small part in their entire curriculum, but we give them levels 1, 2, 3, 4, and 5. They get assessed on a regular basis by all of the people who are supervising surgery. They receive this feedback, and they are trying to attain a level where they have full competency on their own. And so I mentioned this level of curriculum to show you that Vision Care is an organization that is dedicated to introducing phaco to places where that doesn't exist or is not being used on a regular basis. However, you can see that the challenges that we have, because it requires a lot of effort and time. And so this program that we have developed here, our PTC program, is meant to be just the tip of the iceberg, an introduction to be able to introduce some of this technology. And so I have been very privileged to work with many of you for the last decade or so. And I just wanted to go over what the phases are. So we've broken down those same components of our curriculum to be these 4 phases of this course, obviously in a very shortened version. And so the first is the didactic curriculum. A part of that is our meeting with you over these Zoom meetings in order to talk about certain issues, but we're asking you to take this CyberSight online phacoemulsification course. I'm sure many of you have already seen this. This is put out by Orbis, and this is a course that goes through in detail all the steps of surgery. They now have a new component that I will demonstrate to you, which is a video-based course. The second phase of this program is to perform the dry lab and wet lab practice. We're going to be providing to you these simulated eye kits. It'll either be the Kataro kit or the Bionico, which are these very well-established eye models. We're asking for you to then record your practice on these kits under supervision, and then you will upload them, and then we will review them, and we will discuss them at our the following meetings. Number 3 will be the training, performing surgery. And so in phase 3, this is where you will observe and sit next to an established surgeon and participate in parts of the surgery, as we mentioned, backing in. So starting from the insertion of the intraocular lens and then coming forward to the beginning of the case. And then the 4th part, phase 4, is when we will have you do entire cases with the trainers that are coming from the US and from Korea joining established ICAMP. The 4th part of this is the feedback, which is important for you to have to know what is the assessment of, whether you're meeting the criteria to be able to perform these skills. We would have you record your cases, and then we will review them as they're uploaded onto our portal. The rubric that we will use is the ICO Oscar scoring rubric, and then we will also meet monthly to discuss and answer questions. I'm really delighted. As you can see, we have been holding this course for at least I've been participating over a decade now in Ethiopia, and we are also so delighted to be doing this in Tanzania. So I just wanted to go over the time frame of this particular course, this year's course. And so today is April 14th. This is the introductory lecture. We will be giving to you the information to log on to CyberSight and then to to complete the online course, there's a fundamentals of phacoemulsification, and then there's a video course. They will provide you with certification to show your completion, and we're asking for that to be uploaded to us by June 6th. The second phase is the dry lab practice and wet lab practice. We'll be giving a lecture in May to introduce those kits to you. And then the hands-on practice is scheduled for June. In Ethiopia, I believe it's June 9th through 13th. And in Tanzania, this will be performed during our, after the TOS Congress in June. And so I will be joining you there. I will be there June 23rd to 27th. So I look forward to sitting next to you and performing some of that practice with you. For PTC3, we'll be having a lecture on the techniques of nuclear disassembly. We'll review at that time your videos from your dry and wet lab. So that will be due in July. And then the clinical practice will be for PTC3, that's parts of cases, will be in Ethiopia in August. I will be there in Ethiopia at that time. This will be following the COEXA meeting. And then in Tanzania, those dates are to be determined, and that will be late July, early August. And then finally, PTC4 will be held in September, and I will give a lecture on managing complications in phacosurgery. We will also be reviewing your videos that you've taken from your from your PTC3, your parts of cases, and then we will be doing the clinical practice, and teams will be coming to you in September, both from Korea and from the US. So that ends the lecture for me. I'm so delighted to meet all of you and to share this program with you. We have found that it's been a really wonderful experience, and we're hope that this can be the beginning of a very successful phacoemulsification career. I just want to also share with you. So many of us I know that there are many organizations that are visiting you. I know that my colleagues from Cornell were just in Mwanza in Tanzania. I know that Susan McDonald is also doing a lot of work out there. I know that HCP and our colleagues from, from Utah are working a lot in Ethiopia, building new centers. We're also, hearing from them a lot of the work that's being done. We like to collaborate and try to build upon the skills and all the resources that they're also giving. And so one of our collaborations is also with Orbis. For those of you who may have met Hunter Cherwick, who has been really a pioneer in bringing a lot of this material around the world. So we have been talking together about how we can work well together. And I just want to show they are the ones that have come up with this course that's online that we felt is very good. So I'm going to just share to make sure everyone understands where this is. So this is the CyberSite website, and you can see this here. And so what we're asking you to do is make sure that you sign in, create an account, and then you're going to look here at these online courses. And I'm going to show you the two courses that we're asking you to complete. And that is here on the left-hand side. You can see there are many, many courses that you can take. If you click on cataract here, and then I'm going to go to the English versions here. So here are their 4 courses, and you can see, obviously, for those of you who are already performing manual surgery, you will not need to do these 2. But we're asking you to complete for us the fundamentals of phacoemulsification surgery, and also the basics, which is a video course, which is new for them. And so once you do this, you can see that these are the objectives. You will understand, all of the, let's take a look here. And this is essentially a didactic lecture series, which is quite good. And then this is their video course. So this is something that's new. And so we're asking you to sign on. And this is a surgeon that's from, I think, Shreveport, who basically goes over and shows his videos of all these steps of surgery. And then lastly, I just wanted to show you our website, which has been overhauled recently. And so we encourage you to look here at Vision Care USA. And what we will have here, which is not available now, but which is what we will be using for the uploads, will be here. Hang on one second. And that is, actually, I can't see it here. Oh, there should be a trainee part of this website. The trainee part, you'll receive a name and password so that you can log in here. I'm so sorry, I'm having a difficult time
Right,
manipulating.
so the button where it says PTC login in the right-hand
Yeah.
corner.
Unfortunately, because I have too many windows open now, I can't actually see it. So you can see where it says PTC login. That's where you're going to go, and you're going to receive information there as to, hang on one second. Yep. I can't access, I have too many windows open here, so I can't access that part of the website. So I just want to say, thank you to everybody for attending this orientation. I also would like to introduce Dr. Grace Bay, who is here. She is also one of our instructors for this course. She visited some of you in Ethiopia, I believe, last year. So Grace, did you want to say any words?
Hi, everybody. Thank you so much for joining this course. I think you're going to really find a lot of good information to help you and guide you through your steps. Dr. Lisa Park, Amy I, and Dr. John Park, we're all really excited to launch this training again. And we hope that you could make a really good experience out of it. And please don't hesitate to ask any questions, any comments you may have. I think we communicate through the Google Doc and Google, right? Is that right, Amy?
Amy will share the means of communication
Awesome.
as it changes over time.
So
Yes.
yeah.
Perfect. I see some familiar faces too, so hello. It's good to see all of you, and I hope to get to know the newer trainees as well. So welcome.
And lastly, as you know, we are, our objective is that even though we teach this course, that that in each country that you will develop this teaching program, so that obviously it takes a lot of effort and resource in order to teach this surgery. And so we're also supporting and thanking all of the trainers who are here on this Zoom call, and that we would also like to equip those of you who are teaching others in order to have those resources and tools to be able to do so in your own country. With that, I think that's all for me. Amy, is there anything else we'd like to announce?
Yeah, so as Dr. Lisa Park explained, our next webinar will be sometime in May. And once that date is confirmed, we will be sure to let you know. Thanks.
Are there any questions? Thank you so much for joining, and we look forward to seeing you again soon.
Thank you very much.
Thank you, everyone.
Night.
Thank you
Good
very
night.
much.
Thank you, everyone.
Thank you.
Good night.
Thank you. Good night.